Folks at the Ajax site, are you good? Can you hear and see everything? Okay, good. Right. So we have quite a few things on the agenda. This is our first town hall for 2015, and it has been a busy 6 weeks, I have to say. We brought off to a really exciting start for the year, good and bad. And so there are a couple of things that we thought we needed to update everyone on. And we're going to talk a bit about some of the leadership changes. I know people want to hear about that, but also wanted to spend the bulk of our time acknowledging some of the organizational challenges. Let me just use that term, that we've been facing. And I'm going to be as honest as I can in terms of sharing information. And my hope is that you will also be as honest as you can, because a town hall doesn't just have to be about me talking and you listening. It'd be really good to have some dialogue, and I'd love to hear about some of the experiences that you're all having as well. And if you have some good ideas and solutions, I really want to hear those too. So organizational challenges is what we're really going to focus on, and then give you some updates on some of the things that we're doing in terms of capital, strategic planning, preparing our annual quality improvement plan, some training updates, and of course, privacy. So, as you know, Rick Ganderton announced retirement quite some time ago. It was in October of 2013. And the board didn't initiate a search right away because, as you know, at that point we were having some discussions with the Scarborough Hospital about the possibility of a merger. So it wouldn't have made sense to begin searching when we didn't know if we were going to be searching for a CEO of a merged organization or just Rouge Valley on its own. So I just wanted to say that because I think there may be a perception out there that this search has been going on since Rick announced his retirement, and why is it taking so long? And that's actually not the case. The board didn't begin to actually go out looking for a new CEO until we knew that the merger wasn't going to go through. So they are actively involved in a search with the help of some consultants that are helping them to identify people. And once we know and there's a name that we can announce, you will hear about that. So in the meantime, the senior team has been holding the fort, and I've been asked to be in the acting CEO role, and the title that we're using for that is Interim Chief Operating Officer. And the reason is, even though Rick is not here physically, he is here in many ways. He's actually providing support remotely. And we hear from Rick every single day. It's not much of a retirement, to be honest with you. He has dialed in to 3-hour board meetings, to senior management team meetings that we have every Thursday afternoon. So he is still in the CEO role, but I'm here on the ground physically dealing with a lot of the day-to-day stuff that he just can't do from where he is. And of course, everyone else has stepped up to help with that. And I wanted to acknowledge a couple of people specifically. Amelia McCutcheon isn't here today. She's on vacation. But she has taken on temporary leadership for the women's and children's portfolio that I was responsible for. And Glenn Boatswain has moved into the role as the interim director for the women's and children's program. And Glenn is here, and I do want to acknowledge her for stepping up. It wasn't as though she didn't have enough work to do before I added to her plate. And all of the members of the senior team, I think we're all just trying to pitch in and help each other through some of the challenges that we're going to talk about in a second. And one of the people who has been so instrumental for the last few years in dealing with flow issues has been Cheryl, and unfortunately Cheryl tendered her resignation a little while ago, and she is going to be with us for a couple more months, and we're working through a transition plan. Cheryl is really committed to getting some things done before she goes, but we're so sorry to see Cheryl go. She's accepted a wonderful position in Burlington, and will be moving there with her family. So is Cheryl actually here? Because I'm not seeing her. Yeah, I was in a meeting with her earlier. She's not here, but we send her our thanks anyway. Okay. So, organizational challenges. This is a really tough town hall to have, because every day we are hearing about the frustrations of our staff that are working so hard and trying so many ways to kind of just stay afloat with what we've been dealing with. And the big thing that has been impacting us lately is increasing patient volumes. we are experiencing a surge at both sites. And this has been going on since December in a big way, but maybe even before that as well. We had a number of challenges, and there were a lot of factors. December, of course, we were dealing with the holiday season, and a lot of family doctors and other community services, they closed down for a bit over the Christmas holidays, and physicians take holidays and things like that. So that always impacts us. We expect that to happen. We had the flu season, and we always know when the flu season is coming, but what we didn't expect was that the flu vaccine wasn't as effective as it normally is, because there was a change. It's called an antigenic drift, and the kind of flu virus that we actually experienced was different than what the vaccine had been mixed up for. So it was only about 52% effective. So a lot more patients were coming in with the flu, staff were sick, physicians were sick. The other thing is it also impacted a lot of the long-term care facilities. People living in nursing homes were getting flu, and some of the nursing homes that we rely on to discharge patients to, they were closed because of flu outbreaks. On top of that, we had experienced a fire at a nursing home in Whitby called Fairview Lodge. That happened on October 27th, so we lost 200 beds out of the long-term care system, and the new home hasn't been rebuilt yet. So we were dealing with 200 fewer beds than we normally would have had. And then if that wasn't enough, late last month, the CCAC went on strike. So they're dealing with a labor disruption there. Around the nurses that work for the Central East CCAC. So we've had all of these things, and I was thinking a couple months ago I was watching 60 Minutes, and they had a show on about a plague, an outbreak of the plague in Madagascar, and I thought, well, that's the only thing left, I think, is the plague. You know, we've had fires and Ebola, and it's just been a very, very difficult time. And let me show you some of the numbers. I'm going to do it a bit out of order. So in the emergency department, and there's folks here from the emergency department, you're living this every day, I don't have to tell you. Although it's a little bit cut off. Although we've had, we see a really, really high volume of folks in our emergency department. So both emergency departments are seeing more patients than they were actually built for. Even the brand new emergency department at the Ajax site, that's only 5 years old, has already outgrown the capacity that we anticipated. So in the first 9 months of the year, we saw close to 100,000 people through the two emergency departments. It's actually down a little bit 1 year over the next by about 2%. But the interesting thing is that the types of patients that we're seeing has changed. These are sicker patients. And one of the ways that we know that is when you look at, oh, I thought I had a pointer, but I don't think I do. When you look at the ED admit rate, so the fourth row on this slide, it says that last year, in the first 9 months of the year, we admitted about 7% of the patients that visited us in our emergency departments. This year, it's up to 9%, right? And by the numbers, you can see that we've actually admitted in the first 9 months of the year over 1,700 more patients than we admitted in the first 9 months of last year. Right? And those patients need beds. That's the equivalent of about 6 beds right there in terms of the number of additional people that we're admitting. And we can also see that reflected in the indicator. It's called weighted cases, and you don't need to know the details of that calculation, but weighted cases is an indicator that lets us see the acuity of patients. So not just the volume, but the acuity is factored in there. And you can see that acuity has gone up, both in terms of the ED patient population and the acute inpatient population. We're seeing an increase. So this is having a huge impact. These patients require more time and probably more testing. And the medication reconciliation probably takes longer. So there's this whole impact of that growth in acuity. I wanted to go back to this. So what that means is that we've actually had to open more beds than we've budgeted for. And the horizontal line, that is at 462 beds, is what we had budgeted for across the two sites. And you can see that from August, every month, the number of beds that we've actually had open has been increasing to the point where we're at about 493 beds. So on a typical day, it's not unusual for us to have 30 or 40 more beds open and in use than what's actually in our budget. And this is because before we look at numbers and dollars, we put patient safety first. We know that although this is not the best solution over the long term, we can't afford it. But often we just don't have a choice from a patient safety perspective. So these 4 quadrants, I wanted to put this up just to put things in a bit of perspective. You know that we talk about our strategic dimensions at Rouge, and these are the things that define how we want to provide care and the kind of hospital that we want to be. So we want to be a place that provides good access to service, service excellence, good quality care. We want our teams to be engaged and involved, and also we want to be fiscally responsible. We know that we're funded with taxpayers' dollars, right? And we have a responsibility to provide good stewardship in terms of how we spend that money. And the challenge that we all have as leaders and staff is to balance all of those things. We can't just focus on one and not the other. And that's why this is so hard, because you try to provide better access, but you fall down on the fiscal side or on the team side, because maybe we're pushing our staff too hard. And I wanted to hear from you about what some of the things are that you've been experiencing. As you think about those 4 areas, what are some of the things that you're noticing over the last couple of months as you deal with these challenges? Any thoughts?
I think the access to service hasn't changed. We never close our doors to anyone. And I believe that our service excellence is as it always has been. I believe that people are working harder and maybe longer and doing more with less. But that's what we do because that's what we're here for. And I think as far as team engagement, I think there's lots of people in this hospital that have vested interests in this hospital and want to be as engaged as possible to make sure that this hospital survives and thrives. So as far as fiscal responsibility goes, I leave that to you.
Any other comments? No? I did bring, some of the staff in the emergency department have been giving this a lot of thought, and 5 of them got together and wrote a letter the other day, which is very, very well written, and it outlines a number of the issues. And I won't read you the whole 2 pages, but I had highlighted some of the things that they wrote. You know, they said, as a collective whole, we've accumulated a list of concerns to address to you in the hopes of working together and interdepartmentally to help solve or elevate some of the ongoing issues we're experiencing, which is really good, because the important thing is not that we have challenges. Every organization has challenges. It's what we do about them. And I loved that opening of the letter, because it was saying, you know what, we know that we're in this together, and we're going to tell you what the issues are, because as leaders we can't fix things that we don't even know about. So that was very, very positive, that the dialogue is happening. And then they go on to say, patient safety is always of highest concern to us as nurses. We strive to provide the best patient care to those who have come to us for assistance. Unfortunately, that does not always seem possible. And at the end, they say, in the end, we all want what is best for the patient. So that's so positive, and I know that that's how all of our staff think. So I anticipated some of you might be a bit shy in terms of speaking, so I put down some of my thoughts and observations in terms of what we're seeing. And from an access perspective, what we are seeing is, yes, we are finding we have longer wait times in the emerge, delays getting people into those inpatient beds because of the delays in getting people out and getting people home or into a long-term care facility. And while some areas are struggling to manage increased volumes, like in the emergency department or medicine, we also have the issue with other areas struggling with volumes in a different way. In some of my areas, like in the birthing center, we're struggling because volumes have actually gone down. And women are not having as many babies as they used to. And that creates other issues from an efficiency perspective. So we need to be aware of both of those challenges. In terms of service excellence, what we've seen, unfortunately, I was looking at our metrics for the month of December, and a lot of our quality metrics suffered in December. We see that quality suffers sometimes due to busyness, and we have to look at our processes around that, because our patients expect to receive consistent high quality whenever they come in. And we know that quality improvement work gets put on hold because we have to deal with day-to-day crises. And we have seen a bit of an increase in our patient complaints and a bit of a drop in patient satisfaction. On the team engagement side, we're well aware that we're seeing low morale right now, and I love the letters like what I've read, because at least people are talking about it, and we're seeing that high frustration, not only amongst the staff, we're getting letters from the physicians as well, who are also frustrated by some of the conditions that we're having to manage through. And high sick time. As I mentioned earlier, our staff have been impacted by the flu this season as well. Fiscal responsibility, I mentioned the 30 or 40 unbudgeted beds that are in use. We're spending more than budgeted for, and that's just not sustainable. And it reminds me of when I came to the hospital almost 7 years ago, and we were going through that difficult time. I know some of you have been here longer than me, so you know that we were in that position where we were spending more money than we had. We didn't have money left at the end of the year to upgrade equipment and fix the building and do all of those things that are so important. If we want to invest in new technology like CPOE, practitioner order entry, we need that, because that's going to help us do medication reconciliation, and it helps us to automate our order sets, and that impacts quality. So some of the things that we need those surpluses to help with actually will help us to drive the other quadrants here. So everyone's done a great job, and I won't wait till the end of this presentation to say thank you. I could say it in the middle. Thank everyone for all of the hard work that you're doing. We know that you're going above and beyond every day just to keep things flowing. But our current situation just isn't sustainable. So some of the things that we've put in place, and we're looking for more ideas all the time, we have put the incident command center structure in place. So that's something that we use when we have significant crises, that we know it's more than on the shoulders of one person to solve. And actually, that's why I decided that I would speak to these slides as opposed to asking Cheryl to come and speak to it, because it's not about the emergency department and medicine, and I didn't want Kathy to speak to it because it's not just a finance issue. I really wanted to send the message that this is a corporate issue that affects all of us. And we all need to think of things that we can do to solve this issue. So the Incident Command Center brings together all of the senior management team and some of the directors and the managers on call, and we meet as we need to meet. Whether it's nights or weekends, we call together the command center to help us deal with significant quality issues and flow issues. We have the SWAT teams that we put in place last summer. So that again is VPs and physician leaders and staff, and they actually go around and visit as many patients as we can on a daily basis. And we're looking at admissions and seeing if there are other appropriate ways that we can help those patients rather than admitting them. And we're also trying to facilitate timely discharges and get people back home. We're maximizing the use of the staff resource team. So that's our pool of staff that we have to draw on. And sometimes even that is not enough. And we have had to approve overtime. And staffing remains really tight, because even if we wanted to, we're able to open 100 more beds, we don't have that many staff. We don't have the staff to staff all the beds that we want to open. So our focus over the next couple of months is going to cover a number of things. We need to look at how we can manage volumes, how we can manage length of stay. We're looking for new ideas on how we can keep a lid on our costs. And the one, unfortunately, it's kind of hidden on this slide, but it's actually one of the most important bullet points that I had there. It says staff ideas. And all of your areas are supposed to have idea boards so that we can capture your ideas. And we think this is so important that it is one of the things that we report to our board of directors every quarter. They see how many ideas our staff have brought forward that we've been able to implement. And that's going to stay on our scorecard again next year. So that is really, really important. Okay. So really good point. So just to repeat that, because folks at Ajax may not have heard, what Pauline is saying is how are we developing the services in the community, for example, in long-term care homes, so that they can hang on to the residents rather than bringing them to the emergency department, and offer things like IV therapy and other types of services. And so what are some of the partnerships that we're forming in the community? And I know about some of those examples. Did you want to speak to any of those, Chris?
Yeah, so the problem is the volume, right? And that there are only so many long-term care facilities that the NP staff program can provide that support or service to. So it's really about being able to manage that volume of patients. So some of the patients are able to go back right out of the ED under NP staff. Some of them need to be admitted just because that support isn't available in that long-term care facility. It is on the agenda for the Home First Sustainability Steering Committee. We discuss that all the time about increasing those supports through NP staff.
That would be great.
And there's another initiative that is going on actually across the whole province. I'm going to put Callum on the spot because he's an expert. 30 seconds on what HealthLinks is.
Okay. So HealthLinks is trying to bridge organizations across the whole of the healthcare system, so across all sectors, hospitals, health centers, CCAC specialists, outpatient clinics, and really wrap the points of care for patients around them rather than the other way around. So it's really about transforming people who might be used to managing their particular organization into more like inter-organizational system architects to help bridge that transition for patients between organizations and even prevent the transition in the first place, which I think is what you're kind of highlighting here. So we start to think about how we support each other's indicators for coming out of our particular kind of siloed interest and more to that common value of optimal patient service delivery. So that's a structural change that's happening down the pipeline, and I think Rouge has been key in one of the latest waves of HealthLinks, and I think that hopefully highlights the summary on the spot of what HealthLinks is.
It's really about a common care plan for the patient that everybody can share and have access to, so that when a patient presents to the emergency department and they're part of HealthLinks, we know that upon registration, we can go into a portal, if you will, and pull that electronic care plan out, look at what their plan of care really is, what they need from us, contribute to that plan of care, and then put it back on the shelf when we discharge the patient back to where they're coming from, so the next care provider can pull that same care plan off the shelf and look at what it is that we did in the emergency department. That's what we're really hoping to get to.
So these are examples of some of the things that are happening out there that will hopefully prevent people from even needing to come to the hospital in the first place.
I'm going to speak a little bit about capital this morning. So we have 4 projects that have been advanced through the Central East LHIN. 3 of them at this point in time have actually been endorsed by the LHIN, and we just submitted them to the Ministry of Health about 2 weeks ago. Those projects address the redevelopment of the emergency department here at the Centenary site, the ambulatory care center that we're planning in North Pickering to address the population growth in the Seaton area, and an expansion of beds and the surgical suite and ancillary services out at the Ajax campus. The 4th project that is still before the LHIN is actually a renovation of the tower here at Centenary from top to bottom, and also looking at the impact on those services primarily on level 2. So it'd be surgical suite, diagnostic imaging, and some of the other ambulatory care. Those are our major projects that are on the table right now. We're expecting that by the summer we will hear back from the ministry on the 3 that have actually cleared the LHIN process, and it's currently sitting at the Ministry of Health. In addition to those, we're actually, as part of some of the challenges we're seeing with flow and volume and access and things like that, we're actually also looking at cohorting ALC patients on the 4th floor, the east side. So we're going through a feasibility study for looking at that at this point in time. So if you see us wandering around, Mr. Hill, you know what it's about. Beyond that, with the pressures in the emergency department, we've actually started looking at an interim solution, and that interim solution will be a plan to try and address some additional stretcher capacity down there. And we've got a layout at this point in time that still needs to be vetted and tested and have discussions with the users in those areas. That will likely see us adding up to 7 stretchers in the emergency department, hopefully to help alleviate some of the challenges that we're seeing with respect to medicine and volumes that are coming through the door. There is a risk side to this, but I'm not going to talk about risk, so it's supposed to be a good news story. Finance is here, and where's Foundation? And Foundation is back there. So my take on the risk piece of it is, I'm glad to have you as friends because I love spending money.
Thanks, Rick. So we're looking forward to developing these capital plans, but it's all linked. You know, the ministry doesn't give us all the money we need for these things. That's why we can't just balance our budget. We have to have some left over every year so that we can do these things. And Kathy Campos was telling me earlier this week, it's really hard to go to the bank and ask for a loan when our financial situation is not good. So we cannot follow through on these things until we have a stable financial situation and we have some surpluses that we can reinvest in the infrastructure, the facilities. We have the help of the foundation. Of course, they're going to raise money in the community, but we have to chip in as well as a hospital. So that's why the financial piece is so important. Okay, more good news. Quality improvement plan. Paula, turn it over to you.
Here, I just want to acknowledge Natalie and Pez and her team, of course the quality portfolio, which includes Diane, TMO, Scott Ovenden, and also we're helped by Randy Boudreau. A small group of us have come together to support the organization. Michelle is our executive sponsor in developing what we call an annual quality improvement plan. And this is our 4th or 5th year in the making, as well as the province. The Excellent Care for All Act, enacted in 2010, directs all public hospitals to put forth an improvement plan. And so what is an improvement plan? It's really an opportunity for us to come together as a system and define what and how we're going to improve patient care. And it's based on the model of improvement through the IHI. So it does provide us with a roadmap on how we're going to deliver high-quality health care. It asks us to sort of reflect on our current state, and Michelle spoke a bit about that. Creating a positive patient experience is also a key outcome, and ensuring really that we're accountable to the public with how we're performing to improve quality of patient care. And by doing so, the executive team at Rouge Valley is held accountable for its outcomes. So, but it does take a team effort. It's all of us included, and being transparent. High level, this is where we are to date. There are key process steps. One is preparing the plan, and we started mid-December. Confirming indicators. There are a set of key priority provincial indicators that Health Quality Ontario recommends, and you'll see those in a next couple of slides, and which ones we've selected. Developing those change ideas. How are we going to get to that improvement, and what targets are we going to set, and how will we know that a change is an improvement? Are the discussions that are happening right now? And a draft plan will be completed by the end of March. It will be posted publicly on the provincial website April 1st. So as I mentioned, the activities to date include a progress report, which is really reflection on last year's QIP, and we've received our first drafts of those. We've selected our indicators, still some discussions to finesse some of them. We're in the process of finalizing those targets. Executive leads have been assigned, which essentially is the senior management team. Teams are meeting right now with respect to each indicator to develop those change plans and set targets. So these are the top indicators. Not to go through them in any great detail, they're here for your reference. But as Michelle mentioned, they line up with our 4 pillars: access to care, fiscal responsibility, service excellence, and team engagement, which we can't see there at the bottom. And again, these were built based on a reflection of current performance, our indicators that we selected last year and how well we did, Health Quality Ontario's priority metrics, and certainly what is a priority for our Central East LHIN. So you'll see a couple of new ones there, perhaps home support for palliative care patients discharged from hospital. Medication reconciliation on discharge is also a priority for the organization. And new, and it's also an accreditation requirement, and et cetera, et cetera. So I think that is my last slide, Michelle.
Any questions for Paula? Okay. I did want to highlight something that we're doing that's a little bit interesting this year, and we weren't sure how the board members were going to react. But at the very top of this page, it says that it mentions emergency department wait times for admitted patients. And ever since we've been doing quality improvement plans, that has been on the top of our list. And I think ever since we've been doing quality improvement plans, we've never met the target. And it's not for lack of trying. And this links back to Rick Gowrie's presentation about how we really need to renovate our emergency department, especially at Centenary, and how at the Ajax site, part of the issue is they do have a new emergency department, but they don't have a big enough bed base to get people out fast enough. So we have struggled for years to meet that target. And we know that we have to report on that to the local health integration network. But this year, what we're saying to the board is, you know what? Maybe that doesn't need to be on the scorecard every month because it's always red. And we know that we're not going to be able to make very much improvement there until we can do these physical facility changes. And there are other things that we want to measure on our scorecard. So for example, for the first time this year, we have an indicator on end-of-life care. The number of patients that we discharge from hospital who are palliative and they go home with some kind of a home support. That's new. So we want to be able to include some new indicators. So we're thinking maybe the emergency department wait time. We'll still track it, but kind of in the background, as opposed to on our list of top 10 indicators.
Yeah, I was just going to say that there's so many other external influences on that metric that are beyond our control, and you highlighted them at the beginning of your presentation related to the fire, CCAC strike, ALC issues, which all impact the amount of time that admitted patients stay. So there's a lot of pressures that are way beyond certainly my control, and for most of our control and jurisdiction to be able to influence. I agree.
But that doesn't mean that we're not interested in it. We are, what we're really interested in is indicators 5 and 6, patient satisfaction in the ED. So we are going to keep that, those two on our priority list, because we do want to make sure that our patients have a good experience when they come here. Also wanted to tell you about another type of planning that we're doing. You've heard about capital planning. You've heard about the annual quality improvement plan. We've also started working on a new strategic plan. The last one that we did was approved in 2011, so it's been 4 years. So we've launched a process, and a big part of that is hearing from you and hearing from people in our community. So we've been gathering a lot of information. We've actually been able to do a survey of 800 people, 400 in Scarborough, 400 in Durham, to hear what they have to say. What do they think of our reputation and the brand of Rouge Valley? How do we compare to other hospitals? We've done some focus groups just over the last couple of weeks. We've been able to bring 175 people into focus groups, and 90 of those were actually staff and volunteers that came out to focus groups. So I want to thank Renee Schumann and Margaret Kong and Nick Smith and others that were involved in organizing those focus groups, because we've just seen some preliminary results, and we know that we're getting some really good feedback that will help us to develop a strategic plan. We're also going to be doing some interviews with our local political leaders and community groups. Any questions about that? Okay. Part of our strategic planning process this time that we didn't do 4 years ago was to actually look at our vision. And what is our vision, by the way? Does anyone know? All right, okay. At least people remember it. So to be the best at what we do, and that's been our vision for several years. I'm not saying that we'll necessarily change it, but we're at least looking at possibly changing that, and we're looking at our mission statement as well. Okay, Kathy.
Morning, everybody. So a very quick reminder, you have 2 weeks to get all your staff and all of you, if you're staff, trained on all the mandatory training. I keep droning on and on and on, mostly in emails about this. Just remember that this is not all Rouge Valley training. Some of it is ordered by the Ministry of Labour. Some of it's been ordered by the Privacy Office. I think Thodders is going to talk a little bit more about that. And then, of course, we have our Start and Respond with Heart, which has been around for 2 years. We still have a few folks that haven't taken it, so it is on the list of mandatory training. For your information, we are coming down to the wire. We will be sending out packages to casual staff at home with the links so that they can go in and do that at home, because we know it's hard for them. They're not always at work. But just a reminder, so our numbers are actually up from last week, so we're doing well, and we're on target if everybody keeps going that way to have it all finished by the end of the month. So congratulations to all of you who have put some pressure on folks, unfortunately, to get it done. And I'm hoping that we'll have it all done by the end of the month. We'll keep you updated on numbers. Any questions on any of this? As noted in the email, the senior team has decided that anyone who has not taken the training by the end of the month will not be able to work. So we will be notifying managers based on our main. We're finding a little bit of discrepancy, Pauline, with some of the attendance reports. So Bill's working on that with managers just to make sure that they're accurate.
Morning, everybody. Is snooping on patients worth it? And this is a new campaign started at the IPC about 2 weeks ago. And you will see some of this material now around the building, and also you will get a link to the video, which actually tells you a few things. One is that if you are accessing patient information without a reason, and you are accessing information patient without authorization, you may get into serious trouble. Please attend the privacy training. It's important in order to be able to work on March 1st. Please stay away from where you're not supposed to be in the medtech system, because there is auditing, and we're actually sending messages to people that we find that accessing records without an authorization. And they're going to be, as the law requires us to do, they're going to be consequences. So any questions about that?
Great, thank you, Thodders, and we appreciate all your efforts on this one. You know, it's taken up a lot of your time. Okay, one more slide. So Paula, you need to come back up. Quick update on Ebola.
Okay, the good news about Ebola is that it is on the decline globally. For the first time since June of 2014, the 3 countries in Africa where there's the greatest transmission have seen fewer than 100 cases collectively, which is still quite staggering, but it's a huge milestone in and of itself as far as progress. And those countries, as you see, are Guinea, Liberia, and Sierra Leone. Rouge Valley continues on its efforts to be prepared for Ebola, but before I go there, the good news as well as globally is that Mali has now been removed off the alert list, and so we continue to update our countries of interest that are posted in our EDs and outpatient clinics to be mindful of that. Training began in October and continues today. We've almost got 100% of the key personnel trained in those high-risk areas, but it continues. We must remain vigilant with good hand hygiene and practices and our screening protocols. You may have heard that London Health Sciences Centre currently has a couple of patients under isolation, likely will be negative, and we recently had a negative case in Montreal. The ministry came out with this 3-tier framework, and it's designated 11 hospitals as either testing or treatment hospitals, and the treatment hospitals are Hospital for Sick Children, University Health Network, London Health Sciences Centre, and the Ottawa Hospital. And the others that you see on the page, it's hard to see from the back, are the as testing hospitals. So Rouge Valley has not been designated as one of those. We are considered a screening hospital. So if we were to identify a patient upon our screening at the front door, we would quickly be in contact with public health and the public health labs, etc., to decide whether is this in fact a suspect case or not. And if it is, we would make provision to transfer them to one of the testing hospitals. And in this case, if it's an adult, it would be Sunnybrook. And really, that's all I have to say.
I think you're getting hungry. It's about 12 o'clock. So we will try to have another town hall meeting probably in the next 4 to 6 weeks or so to keep you up to date. But like I said, keep the ideas coming. Speak to your supervisors and managers if you can identify ways that we can do things differently. We need to stay vigilant on so many things, hand hygiene, our finances, everything. We really need to deliver on being the best at what we do, even in challenging times. So I know that you're all up for that, and please speak up when you do feel that you need some support, or you know that you're working in conditions that you're not comfortable with. Please let us know, and we'll continue to do whatever we can to help out. Okay? Thank you.